Good morning. Can you hear me okay? Wow, strange looking thing. Hi, I just unmuted you. How are you guys doing?
Fine.
Can you hear me okay?
Yeah, perfectly.
Okay, good. I want you to put your name. Go to the your profile and click on the three dots. Okay, do you see your profile? It's all dark.
Yeah.
There's a mute button, there's a three dots. If you click on that three dot, it says rename. Put your proper name, if you could. Do you know what I mean? Can you see it?
There you go.
Yeah. Okay, I'll be back. We start in about 15, 20 minutes, okay?
Okay, no problem. Whenever you want.
Okay. I saw you raise your hand. Look at that exotic background. Oh man, the disco.
I only have 1 hour's sleep.
Oh, you're kidding, really?
It's okay though.
Dog, we're repositioning.
All right.
Now, let me show you what I mean here. Hold on.
Hello, John.
Good day. How are you?
Fine, fine. How are you?
Yeah. Have you met Simon, my partner, Simon? Simon
Simon.
Downs. He's a med
Oh,
student
nice to
from
meet you.
Italy. From Italy. I mean, from Chicago.
Simon.
I'm in Chicago. Nice to meet you.
Nice to meet you.
Okay, dog. Here we go. All right, dog.
Oh, looking good.
Zoom. Because people, it's getting into the mindset now of people. I mean, they know what Zoom is.
Mm-hmm.
You know, it's not like connect through video conferencing. People just don't know. But Zoom that you say, I think today, most people know what it is,
Right.
which saves us time, you know, explaining all this. Anyways, dog, let me do some stuff. What I do basically, you know, last minute stuff. Try to notify,
Okay.
like Ike likes to get notified, so let me send him. I blast to important people, you know, the link to get in. I got to write a note to Chandra. No, to yeah. Yeah, it's a kind of like you balance trying to promote and letting people in. Yeah, because you tend to lose sight. Oh, there's Joanna. Like any conference, it starts late. Oh, Dr. Gui from China. Great. Dr. Khalif from Kenya. Dog, this is awesome, man. There's Khalif, raised his hand.
Looking good.
Yeah. You know, some people are regular. Dr. Khalif from Kenya is pretty regular.
Hi, John.
Hey, Khalif, how you doing?
I'm doing well.
I like to pick on you. When things get slow, hey, that's a good background.
Yeah, no, it's actually a TV. I'm sitting somewhere. It's not actually a.
Well, you know, I like to put a dynamic background in. I do that with let's see. With,
Yeah.
I put a nice setting like that, and just have it going on in the background. It kind of looks nice to have like a dynamic background.
Yeah.
You know Simon, right? Simon, do
Yeah,
you know
Simon.
this is Khalif?
Yeah.
Look at Simon. Simon's an expert on
Oh.
backgrounds. Look at that.
Yeah. Yeah. So how do you do that, man?
I just you add the virtual background by enabling it from the Zoom settings.
Yeah.
.com.
Yeah. Choose virtual background,
Yeah,
and then
you can add a photo. If you have the newest version of Zoom, it'll give you the
oh, okay. I just updated it.
good. Yeah, the applet. You upload it, and then you can add any image. Yeah, you
See now it's not very.
That's because you have to update the version of Zoom, and then it'll.
Okay.
That's the old version of Zoom.
Ah.
If you have a green screen, the old version of Zoom will look like that. The newest version will blank out your face. So similar to Google Hangouts. So
Ah. Okay.
just that, yeah, but the newest
Yeah.
version,
So,
it should work fine. Yeah.
Hello, Gilbert. Dr. Gilbert.
all right.
Hello, Dr. Gilbert.
Yes, I'm fine. I'm fine. Thank you.
Well, glad you came.
Yes, yes. From Kenya. From Kenya.
Oh, yeah, Dr. You know Khalif. He's on the other side.
Ye-
Khalif,
Yes, yes, yes.
are you guys in the same
Hi.
building?
Yes. How are you?
Good, good, good. Nice to have you here.
I'm good.
Okay, there you
Okay.
go. Two Kenya doctors. You guys are in different spots, right?
Yes.
Geez, I tell you, we're having a lot of Africans come. That's great.
Yes. What will be the main topic today?
Will be clipping of basilar aneurysm by Professor.
Oh, okay, no net. Okay. Okay.
Yes.
I mean, We're going to discuss also some few questions, like this question here.
Well, you know, okay, we're gonna have to change, Khalif. I
Okay.
apparently doesn't have internet. So he sent a video of a similar talk, or
Okay.
if you want to do a presentation or do some cases, that'd be fine too. What do you think?
Okay, we can discuss some few MCQ questions that I've prepared.
Yeah, that would be great. Why don't we do that? Let me propose that to Ike, okay?
Yeah.
Yeah. Let me see, because it'd be nice to have a better, a live one, you know,
Yeah.
interactive.
Hello.
Yeah.
Hello. The
Hello.
answer for question 1 is B, I think, because it's contralateral.
Okay. Okay. Okay, okay. What we're gonna do, okay, yeah, we'll do this on the fly. Okay, let me get that. I'm arranging this on the fly, so hold on here. Okay. Here's what we're gonna do. Yep. With the early days of television, Simon.
Yep.
Yeah, I had no internet. So what we're gonna do, we're gonna play a video of his on basal tip aneurysms, like 8 minutes, Khalif, and then
Okay.
you can lead the discussion, okay? And,
All right.
you can take it on a case history.
Yeah.
Yeah, you could take us to case history, your case histories or whatever. So why don't we do that, okay?
All right.
Okay, let me start right now. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett for Neurosurgical TV, televising from Miami Beach. There's just a few people on the beach. They're violating the curfew. But anyways, we're gonna shake it up today a little bit. I'm having trouble with internet connections in Nepal. So what we're going to do is we're going to play a video of basal tip aneurysms that I did before. And then Khalif has volunteered nicely to lead the discussion after that. So let me just try to arrange that effectively. And so, and we'll introduce all the panelists after, but let's do this video first. We'll watch this. And then, okay, he wants minutes 4 to 12. He instructed me, so let me play that. Okay, here we go.
Okay.
Now tell me if you can hear it okay.
This is as stubborn as I am, but I'm more stubborn. So you see, that is the aneurysm. You can see that. And these are the two P1s. That is a basilar. There are two small superior cerebellar artery aneurysms. This is, superior cerebellar arteries. That is a PCOM. And this aneurysm is pretty high and it's posteriorly projecting. So because it was high, we wanted to get a projection from low to high. So we had to take off this long clinoid. You can see this clinoid is really long. So we took off this clinoid, we did a transcavernous approach, and you will see how it is done. Yeah, so we have already cut the orbitomeningeal band. Those who have seen my lectures and earlier would be familiar with how the orbitomeningeal band is cut, and then you have the cavernous sinus there on that side. Here I am cutting the dura. This is called the hybrid approach, where if I'm not familiar with where the carotid is, then I can just cut and have a look as to where the carotid is. And also, we are in the cisterns right now. You must understand we are right in the base of the brain, what Bharti was showing. Extradurally, I can get into the cisterns there, so that helps in many ways. One is to get into the cisterns, as well as see intradurally what is happening. So that is the last piece of clinoid being taken out there. And after you take out the clinoid, you have the oculocarotid membrane, carotid-oculomotor membrane, and then you can see that there. That is the carotid there. So now dural opening, and you can see this is the optic nerve. So you're cutting the arachnoid, and then now you have, that is a cavernous sinus there, and that is a tent. That is where the third nerve is going into the cavernous sinus. That's the third nerve.
Hey, John, we can't see the video.
Now I'm going
Okay, hold
lateral
on.
to the carotid. That's the
Okay, yeah.
PCOM. And you
Yeah,
can
I'm
see the
sorry.
clot.
I'm sorry,
Lilius membrane
Khalid, you
is
can't
filled
see
with
it?
clot.
Okay, I'm
We
sorry.
can't see it.
Now I am
sorry.
opening the opticocarotid
I'm
membrane,
sorry,
just
I'm
trying to
sorry.
develop this plane.
Thanks for telling me. I don't see.
Proximal sylvian dissection is also
There you go.
needed
Can you see
here.
it okay?
So
Yeah, that's
we are
better.
doing the proximal
Can you hear it
sylvian
okay,
dissection
Khalid?
as well.
Yeah.
Okay.
Slowly expanding the corridor more and more. And now you can see the liliquous membrane that is between the third nerve and the carotid. You can see the liliquous membrane is being developed now. Now I'm going between the opticocarotid membrane, opticocarotid window, and I'm developing this plane. So cutting the liliquous membrane and getting into the basilar artery now. So that is the basilar. And now you can see clearly, I will show you the third nerve on the contralateral side. Anything above the third nerve is P1. So remember this dictum. This is the only truth in neurosurgery, in posterior fossa surgery. You can see the white thing, that is the third nerve, and above the third nerve is P1. So if this is P1, that's a contralateral P1, that is a basilar, and there is aneurysm. So as we expected, posteriorly projecting aneurysm. So that is aneurysm. It is going into the interpetuncular fossa. There is P1. This is the superior cerebellar artery. This is the basilar artery. And you can see now I am dissecting between the P1 and the neck of the aneurysm. You must understand I don't have any proximal control here. We don't have space to put another clip, and it's a bit difficult. It's a very small window, very high aneurysm. So we are dissecting between the P1 and the aneurysm, so that I get some space. So you have perforators here. You have to be very careful. I mean, if you are not kind to the perforators, they will not be kind to you as well. So you have to be very, very careful in dissecting this aneurysmal neck from the perforators. So earlier, I used to, for the basilar tip aneurysms, I used to put in a small Surgicel and just push the Surgicel forward so that we can avoid the perforators. But these days, I don't do this. So I've got a very good plane between the aneurysm and the P1. And now I will put the clip now. So this is the P1. I have a very good plane. I can see always there is a little bit of blind spot. If there are posterior perforators, there's a bit of a blind spot. But sometimes I dissect the whole aneurysm. If it is a basilar tip also, I can show you some of the videos where we have dissected the entire aneurysm free. We have taken the blood clot out and seen the rupture point and all that. It is much more safer than anterior circulation aneurysms to do this. But sometimes you really don't require this sadomasochistic procedures. So you can directly put a clip and you can straight away. Now I'm going to do this now. Yeah, so the orientation of the clip as well as how you put the clip is very, very important. This window is very narrow, you must understand. So you're putting a clip there, gently massaging the artery, massaging the aneurysm, and then putting, so first clip, not good. So we are going in furthermore. Always err on the side of being more gentle, not on the side of being more brash and more rough. So very, very slow, very, very slow, and just clip. That's it. So that is done now. So we will see now the post-op.
I can hear you. I can hear you, please.
The patient is
You
extubated.
can't
It
hear-
was done
can you
day
hear
before
the video
yesterday.
or
Patient
no?
is extubated. He's obeying commands right
I
now.
can feel the but the
Actually,
voice.
Is excellent.
Khalif, can you hear the video?
So
Yeah, I can hear very well.
That is
Okay.
a clipped aneurysm.
It's your audio settings.
Arachnoid bands.
Gilbert.
These are not perforators. Don't
I'm sorry?
think that they are perforators arising from the aneurysm. They are
It's
not.
now okay. It's now okay. It's
That's
now
a
okay.
P1. That's
Okay.
one P1. That's the other P1. That's a basilar. And this is the same technique that Parthiban showed the cystonostomy. It is the same technique. You dissect more arachnoid and you will be able to do this. So instead of training for a decompressive hemicraniectomy, I think neurosurgeons, as Parthi told, as neurosurgeons, you should start to do microneurosurgery. And then only you will not think that this is very difficult. And this is, you can see the superior cerebellar artery beautifully now. And you can see the carotid, the basilar, P1, and you can see distal to P1, there is no aneurysm filling. So you can see the superior cerebellar there, P1 there, you can see the basilar there, you can see the contralateral P1 taking off there. That is the basilar tip. We are just demonstrating it to fellows and our residents that there is no aneurysm left now. Okay. Everything is good. Okay. And
Okay.
we would like you to see the post-op scan also. It is
Okay,
there.
Khalif.
Okay.
We'll
And
stop that there.
All right.
And we're kind of flying by the seat of our pants. I did have a good internet connection. So Khalif, a neurosurgeon from Kenya, has agreed to take over. Okay, Khalif, it's all yours.
Yeah, so we're not going to pretend that we can interpret what Professor IP is doing. I'm not qualified to do that. Basilar tips are very complex, and I think it's in terms of the complexity of aneurysms, basilar tip aneurysms and the ophthalmic aneurysms are the most complex, and they were the reasons why coiling was developed. So instead, what I'm going to do is, instead of giving commentary on how he was doing the procedure, what we're going to do is we're going to have a discussion on basic sciences of posterior fossa vascular system in terms of MCQs, multiple choice questions, for people who will be preparing for exams like myself. Is that okay with everybody?
Sure.
Yeah.
Yeah. So any residents, fellows preparing for exams in the group?
Yes, me.
Yeah. All right, Hafiz. So
There's no screen
Okay.
this is
on your
the first
presentation.
question I'm going to share.
Okay. Yeah, we can
Yeah.
see it, Doc.
You can see it, right?
Yeah, we can see it. Yeah.
Oh, did I share?
No,
I
I
did not
cannot
share.
see.
You started sharing. Okay, I need to mute you,
Okay.
Dr. Hafiz. Okay, I'm sorry.
Let me share.
Yes.
All right, so yeah, so that will be the first question. So you take 30 seconds to figure out, and then we'll proceed.
Yes.
It's
The
related to
answer
the
is
topic,
B.
by the way.
Yes, the answer is B because it will be contralateral.
It will be contralateral.
Yes.
All right. Any other suggestions? So we need to understand what is Wallenberg syndrome. It's also called the lateral medullary syndrome. It's usually caused by occlusion of the pica or vertebral artery. And this kind of aneurysms of pica or vertebral artery sections. And what you get is the lateral wall of the medulla gets ischemic or impacted. So when you get infarction in this area, it's you'll get an ipsilateral sensory loss on the face with contralateral sensory loss of the body. So lesions or lateral medullary syndrome spares the pyramidal tracts. Many people don't get the pyramidal tract symptoms. Okay, so this is what the clinical will look like. So you get an ipsilateral sensory alteration of the face with contralateral sensation loss on the body. Do you see the picture?
Yes.
All right, I think we got disconnected there for a short while.
No, you're connected, okay.
Am I connected now?
Yes. Mhm. You're
Yeah,
not
can you see
screen,
my-
you're not screen sharing.
I'm not screen sharing. All right.
No, no.
All right, so let me do that. Yeah, the internet, I think, is an issue. So do you see that picture now?
Yes,
Yeah, do you see that picture?
yes. Wallenberg syndrome.
Yeah, so this is the Wallenberg syndrome. It's named after a German neurologist who described this. So you get a lesion or you get a lateral medullary ischemia or infarction, and this is what the patient will present. Patient will present with sensory loss of the face with contralateral sensory deficit of the body. And this is how the patient will look like. All right. So this is the picture of where the lesion will be. So the shaded area is where the ischemia will be if you get a pica of that side occluded. Okay, and you get all those nuclei affected. All right. So the general, these are the symptoms. You get a vertigo because you have affection of the vestibular nucleus or its connections. You'll also get ipsilateral facial pain and paresthesia. And this is because of the descending tracts of the fifth nerve nucleus. And then you get a Horner syndrome because of the descending sympathetic tract are affected. You get dysphagia or diminished gag, basically symptoms of 9th and 10th nerve deficit. You'll also get numbness of arm, trunk, and leg, and this is because of the cunate and Grisei nuclei, which are located in the lateral segment of the medulla. Patient with a Wallenberg syndrome will look something like. Can I see? Everyone see this?
Yeah, your voice
John,
kind
can
of
you hear
broke.
me?
Yeah, your voice kind of broke up. Can you repeat that?
Yeah, can you see what the MRI?
Yes.
Yeah, so that's what the patient's MRI will look like. A patient with lateral medullary syndrome or Wallenberg syndrome. That's where the ischemia will be. Okay. So coming back to the question after the small explanation, the answer is as Hafiz has said. The patient with the with the Wellenbach syndrome will not have an decreased pain and temperature of the body in the ipsilateral side. Okay, it will be on the contralateral side. All right. Then the next one we're going to discuss is this one. Can everybody see this? Can
Yes.
everybody see my slide?
Yes.
Yeah, so we also take a minute. Can everybody see it?
Yes.
All right. So a patient with a basilar tip aneurysm surgery, the highest risk of perforating vessel injury occurs when the aneurysm is directed to which side? Anterior, posterior, cranially, to the right or to the left?
Maybe posteriorly.
Okay, and why do you say that, Hafiz?
Because the perforating vessels go posteriorly usually from the basilar and the P1s.
So, exactly. So the posterior arise from the P1. The P1 is the PCA segment before it's joined by the PCOM. I'm going to show you some images. And these are the parameters that are supplying posters. Remember the anterior thalamoperforated from the posterior. So in this segment, oh, I can't show it. In the P1 are the perforators that supply the midbrain, the thalamus. They arise from there. So the picture. So this is the
Whoop, just hang in there. The Wi-Fi is getting crowded. Be patient. Whoop, he fell off there.
sorry
That's okay.
about that.
That's okay. Yeah,
Yeah.
you fell off on the screen
think-
share there. Okay, you're back on.
Yeah. So yeah, can you see this picture?
Yes.
Yeah. So the perforators are rising from the P1, and they supply the midbrain, the thalamus, and you see how they look like. So there's something called artery of percheron, which you also need to be aware when you're dealing with the basilar tip. Usually the supply is bilateral. So both P1s give perforators that supply the midbrain and the posterior thalamus. But in some anatomical anomalies, you'll find that the artery of percheron arises from one of the PCS instead of two. And in that case, it supplies both sides of the thalamus from one vessel. So if you're not aware and you accidentally clip one of those perforators when you're doing the basilar tip aneurysm, then the patient will definitely not wake up. So it's something just need to be aware of it. And for people who will be preparing for the exams, the MCQ can have something like this. So these are the different ways the aneurysm of the basilar tip can point. It can point anteriorly, it can point superiorly, point it upwards, and it can also point posteriorly. So I want you to see how it looks like when it's pointing posteriorly. How many perforators are on top of the aneurysm itself? So coming back to our questions. Coming back to our question, the basilar tip aneurysm is the injury to the perforators is most likely when the aneurysm is pointed posteriorly, and that's the answer. Everybody will agree with that? And thank you, Hafiz, for saying that. So this is the final one. Can everybody see it?
Yes.
Yeah.
Yes, yes.
So let's go through it. I'm going to show you an angiogram and then an MRI for a patient who's been worked up for chronic headache. And then the question will follow. So this is the angiogram. And this is from a previous multiple choice question paper online. Okay. This is the MRI of the same patient. And this is the question. The vessel indicated by the arrow is?
It's a fetal PCOM.
Anterior choroidal artery. Fetal PCOM is posterior communicating artery. Persistent trigeminal artery. Normal posterior communicating artery, or persistent aortic artery. So in this, the concept is to have knowledge about the carotidobasilar anastomosis, which happens in utero, and sometimes these vessels can persist instead of regressing. They can persist and cause symptoms later. So this artery is what you need to identify. The MRI. Okay, and that's the question. Any
Seems to be the
guesses?
persistent trigeminal artery, I guess it is.
All right, Dr.
Maybe.
Noor is suggesting is PTA.
Yes.
Maybe persistent aortic artery because it's more proximal.
Hafiz is saying it's persistent aortic artery. I want you to look at again. That's the MRI. The brainstem level is a vessel coming from the anterior circulating system, or the ICA, internal carotid artery, and it's pointing and coming towards the brainstem. And that's how it is in an angiogram. And if you look at it, it's supplying the distal basilar. The PCS are rising from this vessel instead of from the proximal or caudal basilar artery. Okay, any more guesses? All right. So more pictures of the same. Dr. Hafiz, do you want to change your answer?
Yes, I think persistent trigeminal.
Yep. Yeah, you're right.
Yes. Yes.
So that's the answer. It's a persistent trigeminal artery.
Can you hear me, John?
Hey, welcome.
Oh, hi. Hi.
Yeah,
Great.
Khalif is doing a super job taking over.
Yeah, so let me stop sharing.
Okay. What do you guys, do you want to take over, Ike, or?
So, Prof. We're just doing some MCQs related to the topic.
Okay. Did you see the basilar?
We saw the video.
Okay. Do you want me to discuss it once more?
I think so. And then some of the questions related to it, please.
Okay. So I will go ahead and discuss that, as well as maybe another basilar. Let me just see if I can discuss another basilar as well. So ruptured basilar. Okay. So I'm going to share the screen. Okay. Are you seeing it?
Not yet.
Not yet.
Okay, it's sharing now.
It's sharing now?
Yes.
Yeah.
Okay. So, all right, just wait. Now I'm going to enlarge it. Okay. So now you can see this basilar tip.
Yes.
All right. So what you have to understand is this is the aneurysm. That is a P1. That's a P1. Now, if we had a lateral projection, we would have understood that this aneurysm is pointing posteriorly. So this is one of the most difficult basilar tips to operate. I mean, posteriorly pointing basilar tip is not really great. So this is why I wanted to show this. So let's go ahead. Now, how I'm going is I hardly go the subtemporal way. So I'm going to take all this clinoid out, and I'm going to, after that, as usual, I will do a axial unlocking so that the temporal lobe completely moves away out of my vision. I mean, the temporal lobe moves away. So what I'm doing is, this is the temporal lobe. I want it laterally moved. And then when I move the temporal lobe away from the cavernous sinus, what I get is that an unobstructed view towards the interpedunculaar system. So, and also I do this sagittal unlocking. Here, obviously, there is no aneurysm in paraclinoid, so I can take off the clinoid as a one piece. There's no problem. Okay, only when the paraclinoid aneurysm is there, I had to go and very carefully drill it. Now you see that is the optic nerve. Okay, that is the optic nerve, and that is the carotid. As usual, I dissect with a suction and a patty, and that is the third nerve. So you can see the PCOM there. Can you see? And that's the membrane of Lilliquist. So you are clearing it off all the blood, and then you are dissecting between the optic and the carotid, keeping in mind that the ophthalmic can sometimes be there, using a diamond knife just to dissect the proximal sylvian to get more space. So you can see the carotid there, and you can see the temporal lobe there. You can see the clot. Now, between the carotid and the third nerve, this is the carotid, that's the third nerve. So I'm between the carotid and the third nerve, I am dissecting the vessel. Now I have gone back to the window between the optic and the carotid. So that is a PCOM. So all these windows are filled with blood. So you have to be very careful because the aneurysm is right there and you cannot go and be careless. So we are opening up, slowly we are opening up. Now we are finding the basilar, anterior border of the basilar. Lot of arachnoid adhesions. So he's slowly taking out all the adhesions. You can see perforators there. Now the contralateral third nerve, you see that is the point, Now if you will see, I am going to dissect on the, see that is the contralateral third. Can you see the white thing? Can you see the white thing?
Yes.
That is the most important thing. I am going to show that to you again, okay? I am going to dissect, and I have to find, okay, that white thing. If you see that white thing, that means anything above that white thing is PCA. Anything below that white thing is superior cerebellar, and that is a basilar. So this is the most important thing that, see, that is a contralateral third nerve. So if the contralateral, that is a contralateral third nerve, this is the basilar top. There will be superior cerebellar here, that the basilar trunk should be here, okay? So that is what orients you, okay? So that is the basilar trunk. This is the superior cerebellar. These are the P1s. The aneurysm is probably somewhere here. So now this is my idea, okay? Now I'm dissecting. Yes. Now I'm dissecting. So that is a P1, that is a P1. It's a posteriorly directed aneurysm. I'm putting a patty and I'm dissecting above the aneurysm, okay? Now that is an aneurysm. I know that that is an aneurysm. That is a P1. So I have to get space between the aneurysm and the P1. You see? So I have to dissect this area. Are you understanding?
Yes.
Yes.
So I am slowly dissecting between the P1. You must understand that there is no temporary clip here. So there is no control, and it is not an unruptured aneurysm, it's a ruptured aneurysm. It can go off any time, you know. That is the thing which you are working. So here you have to be very, very careful. Okay, you don't want unnecessary movement. So you are slowly dissecting between the P1. This is the basilar. That's the P1. That's the aneurysm. Okay, so you are dissecting between the aneurysm and the P1, trying to make some space. So as long as you don't touch the top of the aneurysm, I mean the fundus of the aneurysm, you're kind of safe, you know. Usually, I mean, I've had experience where the aneurysm is torn from the base. Maybe I can show you some videos of that, but usually it doesn't happen. The aneurysm doesn't tear from the base. So now I have got space, you see. I'm pulling up the perforators. So, and I'm pulling up the perforators, and now I've got space. Okay? There, my suction is showing that I've got space there. That is a space. Okay, that's enough for the clip. So I'm looking for space on this side now, and I think I've got space. Okay. So you're going with the clip. I cannot push it in, so I'm just trying to contract this aneurysm. You know what? By contracting, what I do is I dissect. When I'm contracting, I dissect actually. Okay. When I clip partially, I am actually dissecting the base. So that you should not attempt to clip at one go. You should do this motion, slowly massage the aneurysm so that your clip is dissecting. Okay, your clip is slowly dissecting. And you can see what is beyond the clip. Are you understanding?
Yes.
Yes.
So, so you clip again, you see if it is okay. If it is not okay, now you can see the aneurysm completely white, no problems. Okay. So that is the P1. That is the basilar tip. That is another P1. The aneurysm is completely clipped. So that is P1, P1, superior cerebellar that side. Okay. You inspect everything. That is superior cerebellar on this side. And you can see that this is the carotid, that is a PCOM, and that is the basilar, and the P1, and the aneurysm is clipped off. Okay?
All right.
Right.
I have a
So I'm
question. I have a
stopping to
question.
share.
Go ahead.
Oh, yes. What will be the complication?
Beg your pardon?
What will be the complication of the procedure?
What will be the complication of the procedure? I didn't understand.
Yes. Yes, exactly.
You mean to say what can be the complications of the procedure, isn't it?
Yes, yes.
Because this patient had no complications. He comes walking to my office all the time. But when you do this thing, then you can have a premature rupture. I can show you, maybe I can show you a premature rupture.
Okay.
If there is a premature rupture, you have to go under cardiac arrest. You have to go under.
اليوم اصوت ما بيبطلوش وافصلهم عن بعض. البت ماي دي فظيعه.
I didn't understand that. I didn't get you. Maybe
ملك يا مايك. ملك. تعالي هنا.
Who's this?
Please, could you mute people? I mean, like.
Yeah, everyone not speaking, please mute. Please.
أنا مش عايز أسمع صوت.
I hear some children. Everyone is muted, but I hear some kids.
أنا قلت إيه؟ عايزين تلعبوا؟ اتلعبوا. هتعملوا دوشة؟ لا.
Okay, sorry about that.
Okay. Yeah,
ahead.
so somebody was asking about the complications. So you can hear me now?
Yes.
Yeah, so the thing is, the premature rupture is a problem. So we've had this situation sometime, but you know, we use adenosine, so we go under cardiac arrest and then we clip it. I mean, this is not a big complication, especially in patients with heart problems and all. Using adenosine, the anesthetist may be a bit worried about it, but otherwise, not really much of a complication. Well, I've had some experiences where I clipped off some of the perforators in basilar and then the patient never woke up. So this can happen. Sometimes the clipping is very beautiful, but if you haven't seen the perforators on the pre-op scan, and sometimes it can happen that you clipped off the perforators and then you can have a problem. These are the two major complications. Once I've had once when there was a patient lady with a connective tissue disorder. And then once we were clipping the basilar, what happened is the ICA tore. And then we had a lot of problems. We had to repair the ICA with clips, and then the basilar also ruptured. So then we had to go under cardiac arrest and go and clip that basilar. I may have the video somewhere. I can show you that also. Would you like to see another?
When we decide to go for surgery, for basilar tip, when we decide that basilar tip surgical or for coiling or other vascular procedures, maybe.
Okay, we don't do coiling at all. We clip every aneurysm because in my center, patients mostly don't afford coiling. So, I mean, I don't like coiling. I am not a big proponent of coiling. And of course, basilars, they say it is easy. I don't know about it, but I know clipping is not very difficult. So I go by clipping.
Sir, what clip do you prefer to insert for the basilar tip? And sir, is there any scope of the tandem clipping technique in such kind of aneurysm, especially with wide neck?
I didn't understand your question at all.
Go ahead. Once again, Noor, slowly, please.
Sir, what clip do you prefer for basilar tip aneurysm? Like a straight or a fenestrated one? Say there are perforators there. So many people say that they use perforating type of clip. And sir, the other question is, what will be the scope of tandem clipping for a basilar tip aneurysm with a wide neck?
Okay. Yeah. So first of all, I don't have much of a preference for any clips. Whatever clip they give it to me, I use it. I generally use a straight clip. I can get away with it. Sometimes you need a fenestrated clip. If the aneurysm is very big, then you want to first clip it with a fenestrated clip and then clip again because the posterior part of the aneurysm has to be taken care of first, and then you clip on top of it you clip it with a straight normal clip. So that is if the aneurysm is really big. In that case, I generally go for a cardiac arrest, and I clip maybe midway, and then I rupture the aneurysm. This will help you to collapse the aneurysm, and then you can clip it. I'm not a big proponent of putting so many clips or putting a proximal clip on the basilar. But having said that, there are some aneurysms which are very, very difficult to clip. Some aneurysms where you don't understand what is going on. I mean, even if you have a very good understanding of the pre-op scan, at my stage, sometimes clip aneurysms, when they are extremely big, you really don't understand where the perforators are going to. So, second question is tandem clipping. Well, sometimes, yes. So I use if I'm using tandem clipping, I use it like a temporary clip, which means I clip the aneurysm and then dissect after I clip the aneurysm, it may be an incomplete clipping, but then I can dissect. After I dissect, then
you so much, sir. I got the answer very right. Thank you so much for the very nice explanation.
Yeah. Thank you, Prof. Just wanted to, we were discussing some questions related to the topic. Do you want to?
Would you want me to show another MCA as well?
Sure.
Or
Okay. All right. All right.
Dr. Gilbert, could you please mute?
can you hear me?
Yes, we can hear you.
Yeah.
Ukimaliza kuna hiyo dashboard.
I'm going to share.
Hi, can you hear me?
Yeah.
It's Chris from South Africa. How are you?
Hey, Chris, good to see you, man.
Good, good. Can you just touch on your decision making for a basilar tip if you're going to approach from the right side to the left side, and what anatomical details you use to decide what's the best side?
Yeah, so if the aneurysm, see, generally I go from the right side. I mean, unless you really don't want to go from the left side, because unless you're left-handed, I'm actually lefty. So even then I prefer to go from the right side. It's always easier. But if the aneurysm is leaning towards the left side, and you think you're not going to be able to get between the aneurysm and the left P1 without a lot of retraction, then the optic apparatus comes in between you and the P1 and the neck. So unless you're going to be, if the aneurysm is leaning towards the left side, I don't go from the left side. If the aneurysm is leaning, this aneurysm was leaning towards the right side. Did you notice that? I had to dissect between, I had to dissect between the aneurysm and the right P1. So this was, although it was going posteriorly, it was much easy for me. But if this aneurysm was posterior and left, and I had to dissect it between the left P1 and the aneurysm, this would have been a bit difficult for me. Because my dissection would not be under proper vision. So in this case, sometimes I go from the left side. But if you get all the windows open, that is the main thing, If you get all the windows, you need to do your anterolateral unlocking. You need to do your clinoidectomy. You need to make sure that the temporal base is completely drilled off so that the temporal lobe can completely go out of your way. Then you need to make sure that your sylvian is really, really opened up. You need to open your opticocarotid window. You need to open your lateral carotid window. After all this, generally this is not a problem. Whatever direction you're going from, left, right, or center, it shouldn't be a problem. So people make mistakes by hurrying into the aneurysm. You should not. My advice would be, don't focus on the aneurysm. Just focus on arachnoid dissection. As much as arachnoid dissection that you can do. Focus on all the skull base work. No, it doesn't have to be really big. You can do a clinoidectomy. You can do, transcavernous dissection or pericavernous dissection as I do it. And after that, you open the dura and then start going ahead and opening all the arachnoid, sylvian arachnoid, opticocarotid, lateral carotid, everything you open up. Open up the third nerve all the way, open the arachnoid of the third nerve all the way up to the brainstem. And after this, these aneurysms are going to be rather very easy. So that would be my advice, Chris.
Thanks, I appreciate it, mate.
Yeah, so I am going to show you, and this I'll have to share from the YouTube, I think. So I'm going to first put the YouTube on. Oh, you can already see, right? I'm already sharing it, right?
Yeah. You own the screen right now.
Okay, right. Well, if I do YouTube here, I'm going to go off Zoom or something?
No, just go right to YouTube. You can take us wherever you want, really.
Yeah, that's good because I can show you some. Okay, let me search for this guy.
Go ahead. Go ahead.
Hey, Goi, good to see you, brother.
Yeah, good to see you. And after you finish your sharing, and can I share two basilar tip arteries?
Yes.
That'd be great.
Of course. So we'll have a lot of basilas today.
Yeah,
Can
once
you
you're on
see
this,
this video?
yeah, yes, we can see it. It's loading. Yep.
Okay, right. So this is a reason MC aneurysm. It's not very difficult or anything, but just wanted to show you. So this is the dural opening. This brain was a bit angry, so we have to get into the cisterns. We're getting into the cisterns. Very thick arachnoid. So cutting that arachnoid, proximal sylvian, this is a blood clot. That's a blood clot. So gently cutting all that arachnoid. Separating the arachnoid from the carotid. So you can see the carotid right now. You can see the optic now. Can you see clearly, guys?
Yes.
Okay. So again, no retraction in the beginning, just patchy and a suction. You can see the posterior clinoid process there. So that is the carotid there. And you can see the ophthalmic artery. You can see the ophthalmic artery there. That's the optic nerve. That's the ophthalmic artery coming. This is a quite laterally placed ophthalmic artery. See, that's ophthalmic artery coming there and going underneath. So that is the posterior clinoid process. So you're cutting the arachnoid leading to the membrane of Lilliquist. If it was a basilar, I would have drilled this off. There is no need for an MCA to do that. I mean, so you are seeing the PCOM and the anterior choroidal on this side. You can see that is a third nerve. That's a third nerve. So all that dissection that I told you, I'm going to do it even for an MC aneurysm. You will ask me why. You will understand why. So that is a third nerve. I'm going to open the arachnoid sleeve of the third nerve. You can see what I'm doing? Everybody?
Yes.
Yes.
All right. So I am cutting the root sleeve, arachnoid sleeve of the third nerve, so that this temporal lobe can be mobilized further easily. Okay. This temporal lobe is stuck to the third nerve by this arachnoid. So you are releasing this arachnoid again very gently because it's thick and non-transparent arachnoid. So now the temporal lobe is mobilizing. You see? You don't want to move the third nerve. When you are mobilizing the, again, you are leaving a small sheet of arachnoid over the third nerve. You're not cutting flush on the third nerve. Can you see that? Can you see that there is a small arachnoid on the third nerve? Can you see that? Yes?
Yes.
Right. So that means that we are not cutting flush on the third nerve. So you don't want to manipulate the third nerve when you move the temporal lobe. So that's what you're doing. So gently we're going all the way back, cutting the arachnoid. mobilizing. You see, it's an MC aneurysm, and I'm really not bothered about exposing the MC at this moment. What I'm doing is I'm opening all my windows. Okay, whatever windows that I can open at the moment, I just relax and open them. There is absolutely no hurry. Okay, and after this, you know that the aneurysm is in the superficial region. You can now mobilize the temporal lobe the way you want it. And so your Sylvian opening is going to be rather easy. So proximally, you are seeing up to the bifurcation, and you're slowly going ahead and opening. Put a Surgicel where your suction is, and put in a small retractor just on the frontal lobe, just to hold that, and then you are going to open up. You keep on opening the arachnoid. Make space, open. Make space, open. And it's a ruptured aneurysm. There will be blood, so you wash away the blood. Don't keep extra bleeding. Get a 2 millimeter of arachnoid there, and open it. I'm showing this for the beginners because you guys who hasn't started MC aneurysms, this is a good aneurysm to start with. Okay, you'll get enchanted with this, and then you'll forget about coiling and all that. Okay, so you see how beautiful it is. It's a very simple thing, you know. I'm just making some space, cutting open. There is no increased speed, or I'm not rushing anywhere. So you see the aneurysm. You see the Sylvian dissection, keeping on cutting. So you open the proximal, now you are opening it towards the carotid. Okay. Now already you can see that the second layer is opening up. The second layer is already, that's the second layer. It's already opening up. You see how beautiful that is. Okay. Nothing was visible to start with, all thick, non-transparent arachnoid. But once you open layer by layer, you see how easy it is getting. Now this layer we are opening. Okay. Yes. Going towards the carotid. So we are opening the entire Sylvian there. At this point, I'm not really worried about, or I'm not even looking at where the aneurysm is. I'm just keeping on opening the arachnoid, Sylvian, everything. Okay, relaxedly. I'm not worrying about, oh, where is the aneurysm? Is it going to bleed? Okay, am I near the aneurysm? Nothing. Just, this is one art that you have to understand. A lot of people tell me, I'm so worried doing an aneurysm. How can you just, so I just, my point is wander. You know what is the meaning of wander? Wander, go around, okay? Not aimlessly, okay? Don't wander aimlessly, but wander like there is a meaning. I mean, there is no point going into the opposite Sylvian cistern and opening it. You are opening the Sylvian in the right region. So if you can do that, wander, not aimlessly. Okay. So keeping on opening it. If you focus too much on the aneurysm, then it's going to be a problem. Okay. See how I'm opening up every single strand of Sylvian. Right. Now we come back again. Now you see that the frontal lobe and temporal lobe is beautifully separated. And you see in an aneurysm like that, if you separate it by force or by blunt dissection, this temporal lobe is going to ooze, and then, you know, your surgery will be messy. Here, you see, there is no oozing at all. Now we are seeing the MCA very, very clearly, the proximal MCAs. If I want to put a clip or something, I can easily put it. I'm taking off that arachnoid away from the MCA. This arachnoid is usually thin, so I'm putting in another retractor here. I'm using a needle to open. This is a very good way to open. High magnification and 24 gauge needle. You have to focus on the tip of the needle and then use it to open. See, the focus on the tip of the needle. Your microscope should be focused on the tip of the needle, and then you open. So that is how you go. And then once you open, then you can use your scissors. You know, make the surgery very boring. So many of my fellows and my residents who are in my surgery, they go to sleep. I'm not joking. They go to sleep, you know. I have seen that many times. So the thing is, if that is the thing, that means you are getting better, because you know, when you see these repetitive movements without any purpose, generally you go to sleep. Okay, but then by the time they wake up, the aneurysm would be clipped. So that is the thing, you know, you keep on wandering, and you keep on opening all the things, and then, you know, you are not looking for the aneurysm will be looking for you. Okay, the aneurysm might also get bored and say, okay, clip the hell out of me and get out of here. So what are you doing? So something like that, okay? Instead of that, you make it so messy trying to get into the aneurysm. That's not correct, okay? That way you don't enjoy it. So you see, till now, I'm not even looking at the aneurysm. I'm just going on, opening everything, letting out all the subarachnoid blood, okay? So now we have opened the sylvian quite a lot. A lot of vessels there. These are all things that you will encounter in your practice, okay? So please remember, you will encounter all this. At this point, if you rush, not good for you, okay? So keep on dissecting. Always dissect parallel and then perpendicular to the vessel. You see, this is a loop of a vessel onto that MCA. Can you see that? And you have to see what is the loop attached to. If the loop is attached to only arachnoid, it's very easy to take it off. But if there is a vessel, supposing sometimes there can be a small vessel. Can you see that small vessel? You can take it off. There's no problem. That'll be less than probably 0.5 or 0.2 millimeter. You will see that. A very, very small vessel. So you are first releasing the arachnoid. And then you see this vessel. So you bipolar this vessel. Very gently you bipolar this vessel. And you cut it. And now the entire loop comes backward. See, that's all arachnoid. Now you are seeing the aneurysm suddenly. You see, that is the MCA. That is the MCA under my suction. That is one branch of the MCA. The other branch of the MCA is going that side, and that's the aneurysm. So I am not even dissecting the aneurysm dome because it's ruptured aneurysm, and it is ruptured. You know, it is projecting into the temporal lobe. I'm not taking off the temporal lobe. I just need to find place to clip. So I know there is a branch this way. There is a branch that way. You will see that branch. Can you see that branch there? Can you see? That is a branch that way. This is the branch. This is the branch this way. And that's a temporal, that's a MCA stem. Okay. Now once I get that, this is the aneurysm. So I'm mobilizing it so that I find the edge of the other side of the aneurysm where I need to clip. I know how much large clip I need. And then I see the other side. I retract the aneurysm dome. This is not a good practice, but if you are confident that the aneurysm is ruptured and nothing is going to happen, then maybe you can retract the aneurysm dome like this. Not a great habit. Okay, don't follow it right away. You can, retract the aneurysm dome very gently, very, very gently, so that you can get enough space to put your clips in there. That is because I don't want to dissect the temporal lobe. So I am using a side curved clip to go in. And I am first putting in the side curved clip there. Then I'm going in there, one clip. Once I get both the clips in, both the legs in, and then now I clip it off. And you can see the other branch clearly. That's the other branch of the MCA. So very gently, and then it's finished. Okay, it's clipped. So it's done. Now you can, without any distraction, you can just gently take off all this, all these patties and all, extubate the patient, and by evening sending to the ward. Okay. Instead of that, if you heave and puff and you try to be fast and all that, you will have a patient who will be in your ICU. Okay, I'm stopping to share. Any questions on this? That is a post-op scan. You see, it's beautiful. Okay, there is absolutely no issues, and this guy is out. Okay, right. Okay. Okay, any questions or anything?
So, Professor, the dissection is inside out. So you do the arachnoid release from the cistern coming towards the cortical surface of the sylvian fissure. Did I see like that, or that's a wrong assumption?
No. I never follow any pattern. I cut all the arachnoid that is there. That is all. Whether it is from inside out, outside in, I change sometimes. I just make sure I cut all the arachnoid. That is all. Okay. So there is, for me, in this section, there is no set pattern at all. You see, if you take off all the arachnoid, whatever remains is the vessel. So take out all the arachnoid. That is your policy. Okay. Don't follow principles, because if you follow these principles, sometimes you'll come to a dead end and you'll be confused. So the best thing to do would be cut every single strand of arachnoid that there is. So much so that only vessels remain.
Okay, excuse me. And there is an order to
Hello,
follow.
Dr. Hibe. I have a question.
You have to come from away to the neck, or just you have to cut the arachnoid in any order. Like you have to cut the arachnoid away from the neck, or just you cut whatever the arachnoid thread you see and that's it. Like I would like to not to make a premature rupture of the aneurysm. That's what I concern about.
Yeah, so a premature rupture in MCA is only when you're pushing and pulling on the neck. So you don't want to do that. So in a ruptured aneurysm, especially when you are pushing and pulling arachnoid strands attached to the neck, that's when you have a rupture. So you never push and pull, you just do sharp dissection. And in this way, if you don't push and pull, then there's never going to be a premature rupture. And in an MCA, once you've done your proximal dissection, which means if you have your proximal MCA under control, if you have a premature rupture, this is a way that this is just a way that the aneurysm is very fast. Because if this aneurysm ruptures, you just have to put a temporary clip. You see, I didn't put any temporary clip here. Okay, I never put temporary clips for MCA. So, but if there is a rupture, I just put in a temporary clip and I dissect rather fast. And instead of all these 20 minutes, you would have a 5-minute aneurysm. That is all. Okay, it is not a premature rupture in an MCA is not a big problem. Okay, I'm sure you will come to that stage. For me, premature rupture in ACOM is the main problem, especially some ACOMs which are pointing posteriorly, superiorly. This is a problem. Otherwise,
yeah, I'm asking for further management and ACOM premature rupture. That's why I'm asking. Not about this specific case. I'm asking about if I have a premature rupture in ACOM aneurysm, to avoid the premature rupture, if there is a sequence, like I have to dissect on the lateral aspect of A1, A2, this way. That's what I need to know.
Well, I was thinking that you were asking about this, but well, for ACOM, the best thing would be from going from IC to A1. You first dissect the IC, then the sylvian, proximal sylvian completely. If you don't dissect the sylvian completely, then you are going to put a lot of pressure to retract the sylvian. I mean, retract the frontal lobe. This is very harmful. So you have to dissect the proximal and mid sylvian completely. Then you have to dissect the IC completely, lateral IC and medial IC, opticocarotid and lateral carotid. All the arachnoid you have to dissect completely. You have to irrigate a lot, and then you come into the A1 region. If the A1 is too much posteriorly going, and then, I mean, if the A1 is going too much posteriorly, you can come near to the aneurysm and get the A1. You don't have to get the A1 completely. You can come near to the aneurysm and get the A1, but go from the dominant A1, not from the aneurysm to A1. Go from the A1 to the aneurysm, even distal A1 to the aneurysm. And once you have that, you can go across, get the other A1. And once you get it, maybe you may not need a proximal clip or anything. Do you want to see a rupture, ACOM aneurysm rupture like this, what you said? Do you want to see a rupture?
Yes, I saw premature rupture, ACOM aneurysm before due to dissection, yeah.
Okay, I will show you a premature rupture, and since you asked me for this, I can show you a rupture. This is something very old, maybe, yeah. Can you see this video?
No.
Okay. Oh, I have to share, right?
Right.
Not sharing the screen, Prof.
Okay. Is okay now?
Yeah.
Yes.
Yes.
Yes, it's sure.
Okay. Can you see this one?
Yes.
Yes, I
This is
can.
just for his question. So this is the aneurysm, inferiorly pointing aneurysm. So I am opening a very, very small dural window. This was probably 4 or 5 years back. And I'm opening a 2.5 centimeter incision only. It's a ruptured aneurysm. I'm going to do cystonostomy. Brain is not very lax, so I'm opening the cisterns first. You can see the optic nerve there. You can see the carotid there. I'm opening all the arachnoid there. So that is the optic nerve. The aneurysm is here. The aneurysm is inferiorly pointing. It is in the, you can see the aneurysm there. Okay, that is the carotid. And what is happening is this A1 is going very posterior, very posterior. So I don't have to dissect that. I am going into the aneurysm right now. Since you asked me premature rupture, I'm going to show you that I am going to dissect right over the aneurysm. I am going to take off the arachnoid of the aneurysm. That I will show you now. So first I dissect laterally so that if the aneurysm ruptures, I have control of the carotid at least. And after this, this is the aneurysm. Okay, so and I'm going to dissect off this arachnoid right. I don't even dissect the A1. I am dissecting the aneurysm arachnoid. Now you will see that I am going to dissect the aneurysm arachnoid. I am dissecting over the aneurysm just to expose the aneurysm. I haven't really exposed A1 or anything. I have just exposed the carotid. And see, that is the aneurysm. So
You don't have any proximal control at this level.
No proximal control, nothing. Okay. I am cutting. This is the aneurysm. This is the aneurysm. I am cutting right above the aneurysm. It may look a bit crazy, but well, we have over 500, 600 aneurysms. So we have seen quite a lot of aneurysms rupturing. It doesn't give me a lot of thrill. Of course, it is thrilling to see. I mean, it is exciting to see the aneurysm rupture, but of course, it's not a big problem now. I don't have a, breakdown or anything. So this is the aneurysm. I'm dissecting the aneurysm right away. You see, no proximal control. Okay, absolutely no proximal control. This is the aneurysm. And you see what happened? This is the aneurysm, complete aneurysm. But this aneurysm ruptured from the base. It was crazy, but it was ruptured. This is the rupture point. Can you see the black thing?
Yeah, interesting. Yep.
It's the rupture point. It doesn't matter to me now because that is a rupture point. That is a clot. You can see the clot.
Yeah, I can see. Yep.
Yeah. So you can see the aneurysm and the rupture point is okay. No proximal control here. Nothing. This is now you will see when the aneurysm ruptures what happens. Now I'm trying to make more space between, I know that the A2 is going here like this, okay? So this is the interhemispheric fissure. So I know my clip has to go between these two, between the optic nerve and here. That is where my clip has to go, okay? The entire aneurysm is dissected out.
And why you didn't make like a complete Sylvian dissection, so it's easier to expose the aneurysm and all the vessels?
I know, meaning this is sometimes too much time. So yeah, I mean, I am okay with this. That is why I wanted to show you this picture.
Yes.
Maybe at this stage, I am okay. I mean, I can expose this.
Yeah, it's for a beginner like me, it's very hard.
Yeah, it is not good for you to do this. Okay?
Yes, I know that.
Good for you to dissect above this aneurysm, because if this aneurysm ruptures, if you do not have an idea, this will be, see the rupture now? That is 14:38:45. Can you see the time?
Yeah, I see it.
It is
I
afternoon.
saw it, yeah.
This aneurysm is ruptured now. No proximal control, nothing. Okay. And it is ruptured from the base, not from here. It is ruptured from the base. So no hurry, nothing. Okay. We just put a patty there. Of course, it will not stop the bleeding, huge bleeding. So we put in a temporary clip. That is a temporary clip on the carotid. And I am dissecting the aneurysm. It is 14:40. 2 minutes now. Okay. 2 minutes over. 5 minutes is very safe. Okay. No problem at all. I see clipping of 5 minutes. No problem at all. So 5 minutes is 300 seconds. Long time. Okay. So I am dissecting the aneurysm furthermore. Now I see this is the aneurysm, this is the aneurysm, and this is the vessel. Okay, I am aggressively, I can see the tear. Can you see the tear? This is the tear. Okay, this is the tear. There is nothing to worry about this tear. This tear is near the base, so I have to keep this tear in my clip and save as much of the vessel as possible.
Yeah.
Okay. So that is what I am going to do now. So I dissect further. Forgive the quality of my video because it is done with an old microscope about 5 years back. Now we have excellent quality. So
That's very good. We can see.
I show everybody the vessel now, and now I'm going to be ready for my clip.
Yes, yes.
Yes, so now I'm going to put in the clip, but when I'm going to put in the clip, the suction stopped working and it is bleeding, okay? I'm not happy with this. So I just keep my clip there. Don't move my clip. Just take and direct suction now, okay? And I putting the clip, I am moving the clip towards the tear. This is the tear. I'm moving it towards the tear, as much towards the tear. Incorporate the tear within my clip, and that's it. Now you can see all the vessels, okay? The ACOM, A2, opposite A1, this is the clipped aneurysm. This is the clipped aneurysm, okay? So, not much of a worry, not much of a hurry, okay?
No.
Huh?
Very nice. Very nice.
Yeah, no jumping around, nothing. So, this is, after you do this, then you will see this patient also now very soon, okay?
I have a question for you, Dr. Hipe.
Yes, 1 second, I finish this and then we will have the questions. See, this guy is, no problem. It doesn't look like intraoperative rupture of ACOM aneurysm. It's okay. So I stop share now, okay? Yes. Now, yes, your question?
Yes. Is there any, in the ruptured aneurysm, is there any need for putting the ventricular or the drainage catheter?
Yes, sometime yes. Sometime if there is too much of pressure, yes, maybe we should put in a ventricular catheter to get the pressure down. But usually if there is not much of a pressure, then you can go ahead and, you can go ahead and open the cisterns like what I did right now.
Okay, fine. Thank you so much.
And
Thank
I was telling Goi, brother, maybe why don't you do your session tomorrow? Meaning both the aneurysm, you present it as a session because tomorrow then I will not be presenting anything. You can present it. Is it okay?
Yeah,
okay,
it's
fine.
okay.
That's no problem.
Huh?
Okay.
Tomorrow
Okay.
I'll share 2 basilar tip artery and neurosurgery clipping cases. Okay.
Yes.
Yeah, just text me about the info, okay? The title, Dr. Goy?
Yeah. No, you can write, John, you can write 2 basilar tip aneurysms by Professor Goi.
Okay. Sounds good.
Is that okay, Goi?
Yeah, okay.
Goi?
Yes.
Is that okay? Yeah.
Yes, yes.
So tomorrow will be yours. So I mean, after, if you have any more cases, you can show, and maybe 2 days later I will join again.
Great.
Okay.
Okay, very good. More comments and questions from the panel? A lot of interaction today, Ike.
Yeah. So, well, I am happy. Any more questions? If there is, I can take it. Otherwise, I will carry on.
Thank you so much. Greetings from Finland.
Hello, Joanne.
Hi. That was amazing. Absolutely. Always aneurysms. Wow. Made me happy. Thank you.
Okay.
Joanne,
Forget about coiling after seeing a lot of these aneurysms.
Otherwise, Dr. Hipe,
yeah.
I hope you forget about coiling and other kinds of other kind of ugly things after you see these beautiful clippings.
Yeah. Definitely. Definitely. Thank you.
Okay.
Thank you, doctor.
Dr. Hipe, congratulations for very good explanation for the rapid aneurysm.
Pardon?
He's thanking you. He's thanking you, Ike.
Okay. Right.
Yeah, Professor, we're discussing some few questions which I thought were related to the topic. And with your input as well. We had started before you came. So this question.
I think it is posteriorly. In my experience, when an aneurysm is directed posteriorly, this is like the one I showed you right now. This is when I have problems with perforators. I don't know the answer to this one though.
I think that's the answer. So, and some anatomy on that. The perforators are rising from the P1, and when they are pointed posteriorly is, or when there is artery of percheron, in which case there is only one side of the supply. What the supply is coming from only one side of the PCA.
Do you want to see an artery of percheron? Do you want to see an artery of percheron?
Sure.
You carry on, then I will just look for it. I have a video of the artery of percheron when we were clipping a basilar tip through the suprabrow approach. I can show you the artery of percheron. Let me just see. You carry on with your presentation. I will just look 1 second. Carry on.
So
you carry
this, so this is how it will look like when the aneurysm is pointed posteriorly and all the perforators are on top or around it. So you'll have a blind spot. You'll have a blind spot as you try to put a clip. And if you're unlucky and put a clip on artery of percheron, then definitely the patient will not wake up. Yeah, and as we had discussed earlier, the answer is that when the aneurysm is pointed posteriorly, that's when you have the highest risk of clipping a perforator.
Yeah. So you want me to show an artery of percheron?
Sure.
Yes.
Yeah.
Yeah,
Okay.
it will be great.
How do I okay, I share. Okay. Yeah, so this is a suprabrow approach for to the basilar tip. So that is the optic nerve. This is done in 2012 or something, maybe eight years back. So this is the ICA. I was just showing it in the cystonostomies because they were asking me, is it possible to, you can see now. Let me just show you. I am drilling off the posterior clinoid process now. that is the optic nerve. I'm drilling off the posterior clinoid. This is the carotid. And this is the drilled off posterior clinoid. This is the drill of posterior clinoid. This is one P1. This is another P1. Can you see that?
Yeah.
One P1, another P1. And can you see this artery?
Yeah.
Can you see this single artery? Can you see? One P1, another P1. This is suprabrao approach. So you are seeing the basilar tip right from the front. Okay. This is the PCP which is drilled off.
And this aneurysm was not overriding, right? Not high basilar.
No. It was not. In fact, I had to take off this whole PCP and then I had to separate out this and use a very, very long clip for this one. But I wanted to show you this one. So this is P1, this is P1. Can you see the artery of percheron?
Sure.
Yes, I can see it. But
Yes,
my
yes.
question is, we cannot go for from eyebrow to make a high basilar, right?
Yeah, this would be a bit difficult if it is a high riding basilar because then you will have to remove much more of the orbital roof. So I wouldn't recommend that. I would rather recommend.
This one was low or normal basilar position, not overriding.
It was normal basilar, but I had a large PCP in my way. You see that my PCP removal is not enough. Can you see that? Because the aneurysm is not seen here. Only the P1s are seen here. So I have to cut this membrane of Lilliquist and I have to remove more PCP. And then I am able to clip this aneurysm. Or I have to, after doing this and removing this, I have to shift my microscope angle. Then I will be able to see both the aneurysm and the P1. Okay, so I'm stopping sharing. All right.
All right. And any experience with persistent trigeminal arteries, Professor?
Yes.
In patients with vascular.
Yes, we had once a huge AVM. And it was the AVM in the frontotemporal region, and this was supplied by the persistent trigeminal artery, I remember. Yes, tell me.
So yeah. So this the question is a patient is being worked up for chronic headache, and then you're shown an angiogram and an MRI, and then you have to identify the vessel.
Yeah, so if it is around the Meckel's cave, if it is around the Meckel's cave, it is a persistent trigeminal. It is about the IAM level. This is the Meckel's cave, exactly the Meckel's cave, you see?
Yeah.
So this is the Meckel's cave region. So, and the fifth nerve region, this is persistent trigeminal. And IAM region is persistent otic. Okay, so this is where the persistent trigeminal artery would come.
So sometimes also these vessels themselves can develop aneurysms.
Yes.
Especially at the point where they join the posterior circulation.
Yes, these are not easy to operate because you need a lot of skull base approach here. You need skull base approaches here.
Yeah. So the persistent trigeminal artery supplies the posterior circulation in utero before the development of the vertebral arteries. And they have two types. Type 1, this gentleman described them, the Salzman types, type 1 and type 2. Professor doesn't like the name, so we'll just call them type 1, type 2. And in type 1, the persistent trigeminal artery supplies the distal vertebrobasilar arteries, while in type 2, the PTS supplies the superior cerebral arteries. And the posterior cerebral arteries are supplied by the PCOM in the type 2 anomaly. So there are other persistent arteriosclerosis persistent hypoglossal artery, which arises from the cervical ICA, then persistent protruntal artery, which passes, it can vary from the cervical to the cavernous to the petrous, and then it passes through the foramen magnum. And then there's the persistent aortic artery, which is very rare because it's the first one that regresses, and it arises from the petrous ICA. So all these vessels can persist in adulthood, and they can also develop pathologies. And the last one is persistent hypoglossal artery, which starts from the cervical ICA, and it passes through the hypoglossal canal to join the posterior circulation. So when we're doing the surgeries for posterior fossa, we need to be aware of any anomaly. Sometimes you may think that the circulation is coming from the normal vertebral system, and maybe the patient has an anomaly and the supply is coming from hypoglossal artery. And then if you clip this, if you coagulate or clip this artery or cause a blockage of this artery, then the patient will develop a brainstem infarct and will not wake up from the surgery. Thank you.
If anyone here saw a trigeminal neuralgia due to persistent trigeminal artery, it's written, I know. It's a cause of trigeminal neuralgia, but anyone here saw a patient like that? And how to manage it? Like what to do if it's failed medical treatment?
I haven't seen this.
Mm-hmm.
All right.
Okay, so that is, if that is it, thank you very much for coming today, and we will continue it tomorrow. Tomorrow Goai will be doing it, and he will probably talk on 2 basilar tip aneurysms. And then thank you very much. I hope you enjoyed it.
At the same time,
thank you.
Thank you very much for your time and effort. Thank you all.
thank you for that great.
Thank you very much. I want to know the next time we would meet again.
Tomorrow again, 5 p.m.
Sorry, tomorrow at what time?
5 p.m. Indian Standard Time. John will let you know the correct timings. The same time, tomorrow, same time.
Okay.
Will not, every day on the same time.
Okay.
So see you guys. See you.
All right.
See you.
No, brother.
Thank you. Thank you a lot.
سلام يا فتح الله، سلام يا كتاتني.
Hi, Dr. Gilbert. We're still recording on YouTube. So, Dr. Gilbert, I'm sorry.
I had to share with us the link for the YouTube.
Yeah,
the YouTube channel.
Yeah. I'm sorry. I kept muting you, but you just
hope you will
need
share the YouTube channel.
Yeah. Sure.
Okay, fine.
Listen, Khalif, we have African Grand Rounds tomorrow at 6 o'clock. Okay.
6 o'clock. Okay.
6 o'clock.
Please
I'll
share
let
the
you
link.
guys know. Dr. Kubulo is going to present on some type of back problem.
Okay.
Back, but I'll let you know. And
Excellent,
also,
John.
yeah, Dr. Gilbert, tomorrow, Africa Grand Rounds, okay?
Gilbert, where are you?
He's in Nigeria,
Kenya.
right?
Gilbert from
It's
Kenya.
Gilbert.
Yes.
Oh, I'm sorry. I thought Nigeria. I'm sorry.
Oh,
I thought-
From
wapi
Kenya.
Gilbert uko wapi? Where exactly? Wapi
I'm
exactly?
within Nairobi now. Nairobi.
Nairobi, yeah? Oh, you're in
Yes.
Kenyatta?
Yeah, I will just text
Okay.
you now. I
All
have your
right.
number. All right.
Okay, great. All right, Gilbert.
Yeah. Okay, thank you.
Okay, man.
Okay, Ashri, could you please identify yourself, Ashri? Like to try to meet everybody here. And Victor, I know you're from South America, right? Victor? Gatua. Let's see, Ashri, well, whatever. The dog is still here.
I'm still here. Thank you very much.
Yes, I'm
presentation.
there. I'm from Egypt.
Thank you.
Oh, okay, Dr. Gatua? Gatua? I'm sorry. You're muted there. I can't, we're trying to meet everybody, dog. There you're. It's not a big problem, but it's hello, yeah, we got you on mute. How you doing, Dr. Gatua? Oh, you were on there. Unmute.
Okay, it was an interesting talk.
Okay, very good. Okay, very good. Okay, do I have your email?
I don't think so, but I can share it.
Yes, please do. Do you know how to put it in the chat box below there?
Yes.
Yeah.
I can do that.
Yes, and anybody that wants to receive regular notices, like Gilbert, I don't know if you're on the mailing list, but put your email address in the chat box, okay?
Okay.
Okay.
Thank you so much, Prof.
Yeah, just put your email. Okay, I see, Dr. Gatua, okay. Got it.
All right, thank you.
Okay, very good. Now you'll be getting emails.
I'll appreciate it.
Sure. But now every day here, during these times, IPE has time. And a lot of other people have time to come. Okay, good. I got, a couple I get. Muhammad, yeah, thanks, Muhammad.
I wrote my email.
Yeah, Muhammad, I got it. I got it. Okay, got Muhammad. Let me keep working on them. This is important because we send notices out to everybody about an event. And we also include the link to come in to the event if you have time, because we know the life of a neurosurgeon is chaotic sometimes. Okay. 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 Okay, you got everybody? Dr. Gatua, where are you at? I'm sorry. Go ahead. Where are you at?
I'm in Kenya, in a town called Eldoret.
Oh, okay. Welcome. Have you been here before?
Thank you.
Have you been here before?
This is actually my second session.
Oh, okay. Good.
This is my second time, yes.
Oh, okay. Well, okay, I'm going to close it now, but tomorrow we have another talk, okay?
Okay.
And you'll be getting an email with the link to come in if you want, okay?
Thank you very much.
Yeah, thanks you for coming, and thank everyone else for coming. Good day.